A question. This talk is going to be totally different from what you heard. I don't know why they put it in this session. I hope to make it as interesting as possible. It is on acute comitant esotropia precipitated by excess near work during the COVID-19 induced home confinement. Yeah, so no financial interest. So for most of you who don't know what is AACE, this is acute acquired comitant esotropia. It is nothing but an acquired non-accommodative esodiviation which happens suddenly of acute onset, often associated with diplopia, but comitant, which means it is same in all gaze directions. So you have suddenly someone who presents with a sudden inward squint, which is not there earlier. So it is seen in previously straight-eyed patients, usually seen in children, but can occur in older people also, older children, adults, and even in the elderly. So AACE has 5 different subtypes. Type 1 is a SWAN type, which occurs after a period of interrupted binocularity, like a patch. You put the patient on patch for some, trivial trauma or something. Then there is a Burrian-Francisci type, which is associated with minimal hypermetropia and diplopia, often precipitated by some physical or psychological stress. So the child may be having an underlying esophoria, and suddenly due to stress, it manifests into atropia. Then you have the Belchowski's type, which is seen typically in myopes with convergent spasm and divergence paralysis. So myopes, do you know that they like to look at near more often? They don't like to look far. So they don't use the divergence. So there is divergence paralysis, and excess use of convergence leads to convergent spasm. Then the lesser known ones would be the refractive accommodative type, which is characterized by high hypermetropia, which is adequately controlled by a refractive correction alone. This is the typical hypermetropic accommodative esotropia, which is typically missed and presents to you. Then there is a more dangerous one of an intracranial pathology, which is a lesser common entity, most commonly a posterior fossa tumor like a diffuse pontine glioma, which can present in the form of a sudden onset of esotropia in a child. So these are the common types. So this study was done in the COVID pandemic. With the COVID pandemic, we had the new norm of work, study, and play from home, and everything changed for us. Study, work, everything changed. So with the onset of COVID-19 crisis, we became increasingly digital. A total of 320 million learners in India transitioned into e-learning. And we had a massive rise in people working from home with increasing dependence on gadgets for studies, work, and leisure. So we saw a substantial increase in number of children and young adults with complaints of recent onset of inward squinting and double vision coming to a hospital, which prompted us to do this study to examine the causes of acute acquired comitant esotropia, or AACE, in young children and adults in the setting of COVID-19 induced home confinement. So materials and methods, it was a retrospective clinical study of all those who had acute acquired comitant non-accommodative esodiviation who came to the pediatric ophthalmology department of our hospital from August 2020 to January 2021 during the pandemic season. So materials and methods, these were the diagnostic criteria, all those with acute onset of esodiviation within hours, days, or week, age of onset after 1 year of age, with photographic evidence of previously aligned eyes, a comitant esodiviation with normal ocular movements, no restriction or limitation of ocular movements. So parameters evaluated were these: demographic features like age, sex, occupation, and class of study, a careful history regarding the duration of complaints, any precipitating events, previous and current use of glasses, then the details of near work, including the nature, duration, and medium of work, then the complete ocular examination, including visual acuity, binocular status, both for distance and near, squint evaluation, including the amount and type of esodiviation, an atropine refraction was done in all, and a dilated fundus examination was also done. So ancillary investigations included a complete orthoptic evaluation, including parameters of accommodation and convergence and vergences. And in all patients, we did a magnetic resonance imaging of the brain and orbits. And those which we felt needed a neurological assessment, we sent them to the neurologist. So these are results. We had total 15 cases in our study, 11 males and 4 females. Most of them came to us with complaints of double vision and squint, that is 73.3%, and some with diplopia alone and squint alone. So the mean duration was about 2.98 months, mean duration of presentation, and it ranged from 15 days to 6 months. So age range from 5 to 24 years with majority above the age of 10 years. And the mean age was 16 point. So majority in a group with students, that is about 73.3% with students, so young population, and the rest were employed. There was no precipitating event in most of the patients except excess near work, except one patient who gave a history of fever prior to the onset of ESO deviation. So when we looked at the hours of near work and the medium of near work, we found that the duration of near work ranged from 3 to 12 hours a day for most of the patients, and the mean duration was about 8.6 hours per day, with majority having more than 8 hours of near activity. And the near activity was related to online classes in most of them, that is in 53.3%, official work in 20%, playing games on gadgets in 20%, and religious text reading in 6.7%. And if you look at the medium of the work, smartphone was the most common medium of work in most of the patients, that is in 86.3%. So when we looked at the refractive status, majority of the patients in our study had low hypermetropia, that is about 60%, that is spherical equivalent less than 2 diopters. Few had moderate hypermetropia between 2 to 2.5, and the rest had myopia, that is about 33.3%. Of the myopes, 7 patients had glasses, of which 5 were myopes. And interestingly, 3 out of the 5 myopes admitted to taking off the glasses and doing near work during the pandemic period, because they felt they didn't need to look at far and they could see well for near. They started taking off the glasses and doing the near work. So average esotropia in our study for distance was about 22.73 prism diopters, and for near it was 18.73 diopters. So the range was roughly from 10 to 45 prisms. So if you look at, most of them had double vision. Few were able to have, one patient had fusion and the rest had suppression on Würzburg dot tests. The mean stereopsis was still good, 116.67 in majority. So orthoptic evaluation was essentially not very abnormal, except for 40% of patients showing poor divergence for distance, that is poor negative fusional divergences. Few had high positive relative accommodation and high AC by ratio, but otherwise it was almost normal. So what did we do with these patients? So we decided that all those with pre-existing or newly detected refractive errors were given glasses for constant use. All those with or at the risk of amblyopia were started amblyopia therapy in the form of occlusion therapy. All were advised to restrict and reduce their near activity, especially on mobiles. Those with divergence insufficiency esotropia, in which we found that the divergence was poor, were given divergence exercises in the form of eccentric circles or prisms. In 5 patients, the reduction of near work with divergence exercises was helpful, and it helped them to control the ESO deviation and double vision. But a few patients required prismatic therapy also, like 2 patients were given ground prisms, both with myopia and divergence insufficiency. These were smaller prisms, so we could grind them in the glasses. Now, those with basic type of acquired comitant ESO deviation were advised squint surgery because they had very large angles and they couldn't fuse at any way. So these 4 patients, 3 with low hypermetropia and basic type and 1 with Burian-Francisci type of ASE, underwent squint surgery and regained binocularity. So these are some of the pictures of this patients who underwent surgery. You can see in the first picture, most of them are straight. In the second picture, they started having the ESO deviation when they came to me. And in the last picture, they regained their alignment and binocularity. So this is another patient, an IT professional who developed ESO deviation during the pandemic, had diplopia, underwent surgery and had good improvement. So we found 4 categories of patients with this acute ESO deviation in our study. First was myopes. Now these myopes had divergence insufficiency. Okay, so the distance esotropia was much more than the near esotropia, occasionally almost equal. So they would fit into the Belchevsky's type of ESO deviation. Then we had the low hypermetropes, less than 2 diopters of spherical equivalent hypermetropia with basic type of ESO deviation, same angles for distance and near. Then we had an occasional low hypermetrope with divergence insufficiency esotrope, and the moderate hypermetrope in which the ESO deviation was precipitated by stress, which you could classify as the Burian-Francisci type. But the only common factor in majority was excessive near work. So we had similar literature reports during the pandemic by Aldo Vage et al., who reported 4 cases of acute esotropia during the COVID pandemic. We had earlier reported a series of esotropia in younger patients who did very well with surgery. Then Lee et al. Reported esotropia in patients who used smartphones for longer duration, and Yanwu et al. Also. So, what is the etiology? So, I'd like to just postulate that in the increasing use of smartphones and tablets in modern life, with more and more near work coming into play, everything done at near, both at work and play. So, there is an excessive use of near work, and naturally, stronger convergence in the younger population leads to an imbalance between accommodation and convergence, leads to dynamic activation of the medial rectus muscle and development of a manifest esotropia. And this is more in hypermetropes, naturally because of the greater accommodative demand, and this was also seen in our study. But do you know that even myopes can develop ESO deviation? So this is a postulate which is already postulated by Belchevsky, which we thought worked in our case also. If you have an uncorrected myopia and you hold books or text excessively close to eyes without using your glasses, there is again an increased tone of medial rectus and lack of distant stimuli leading to divergence paralysis, again leading to an acute acquired comitant ESO deviation and manifest esotropia. So 33% have myopes in a study who developed an ESO deviation. So to conclude, we have to really look at the use of increasing digital time in our population. Luckily now the pandemic is gone, but when you have an online class in excess, you have to think of this as an important side effect, acute acquired comitant esotropia, and we have to regulate the hours of online learning and even online play, whatever it is. So that is, the habit of long-time sustained near work, especially on smartphones, has a risk of inducement of AIC, and we should be able to remember this and take specific recommendations to mitigate this undesirable effect. Thank you.